After the normal thyroid physiology in adults, let's move on to some special cases in which the thyroid physiology changes in different conditions like pregnancy or non-thyroid illnesses such as euthyroid 6 syndrome. Starting with the thyroid physiology in pregnancy. The normal pregnancy induces significant changes in thyroid hormone function due to its critical importance for early fetal development. Although multiple fetal processes depend on thyroid hormone, including overall growth, metabolic regulation, and bone maturation, neuronal and brain development are the most critical, as evidenced by the finding of severe neurocognitive deficits in babies born to mothers with untreated hypothyroidism. During the first trimester, maternal thyroid hormone production rises significantly, with total T4 concentration increasing up to 1.5 times that of the non-pregnant state. Although the details are not completely elucidated, it is thought that the rise, at least in part due to the rapidly increasing levels of human chorionic gonadotropin, which shares a common alpha subunit with TSH and acts as a TSH agonist. This can occasionally lead to a phenomenon known as transient gestational thyrotoxicosis, occurring only in the first trimester and resolving spontaneously. The rise in the T4 concentration is also accompanied by a concomitant increase in T4 binding globulin concentration in the bloodstream, which results in greater binding of the circulating T4 and relative stability in free T4 levels. Because of the increased demands for thyroid hormone production, the daily recommended iodine intake during pregnancy also rises. Maternal T4 is transported to the fetal circulation via specialized thyroid hormone transporters in the placenta. Maternal thyroid hormone production increases and peaks during the first trimester of pregnancy and declines steadily afterward. This likely coincides with the development and early function of the fetal thyroid. Measurable levels of fetal thyroid hormone can be detected by the 11th week of gestation, but maturation of the entire hypothalamic pituitary thyroid feedback axis does not occur until the mid-second trimester. Thus, it is thought that properly regulated maternal thyroid function remains important at least until this stage. Thyroid dysfunction is associated with adverse maternal and fetal outcomes. As a result, regular monitoring of thyroid function is a standard component of routine prenatal care. Hypothyroidism is the most common type of thyroid dysfunction in pregnancy, occurring in up to 0.5% of pregnant women. Iodine deficiency is the most common cause of hypothyroidism in iodine deficient regions, whereas autoimmune thyroiditis is the most common cause in iodine replete areas. Maternal hypothyroidism is associated with an increased risk of infertility and perinatal complications. Fetal or neonatal hypothyroidism from iodine deficiency leads to cretinism, a syndrome presenting with the severe growth and cognitive deficit, deafness, and failure of sexual development. Hyperthyroidism, most commonly due to Graves' disease, occurs in about 0.3% of pregnant women. Left untreated, this leads to an increased level of risk of maternal-fetal complications, including miscarriage, preeclampsia, preterm delivery, and abrupt shaped placenta. Now, the thyroid physiology in non-thyroidal illness, like euthyroid 6 syndrome. Many acute and chronic non-thyroidal disease states can affect thyroid function measurement. This phenomenon, commonly called euthyroid 6 syndrome or non-thyroidal illness syndrome, leads to the finding of abnormal thyroid function tests in the setting of non-thyroidal illness in a patient without pre-existing thyroid disease. The most common finding is low serum T3 concentrations with decrease in T4 also seen in most severe states. TSH concentrations remain relatively normal to slightly elevated, but not to the degree of true hypothyroidism. Patients do not exhibit any signs of clinical thyroid dysfunction. The pathophysiology behind euthyroid 6 syndrome remains poorly understood, although severe theories exist. Some believe that conversion of T4 to T3 in the target tissues is impaired during the non-thyroidal illness due to decreased activity of peripheral deiodinase enzymes, in particular deiodinase type 2. Others have investigated the role of cytokines such as tumor necrosis factor alpha, interleukin 1, and interleukin 6 in decreasing thyroid hormone production at the level of the thyroid follicular cell. Others hypothesize that the inhibition of thyroid hormone binding to various thyroid binding proteins may lead to inaccurate measurement of true free hormone levels. Regardless of theory, it is generally believed that patients with this phenomenon are in fact euthyroid and do not have intrinsic thyroid dysfunction. Common states associated with euthyroid 6 syndrome in surgical patients include sepsis, fasting or starvation, trauma, thermal injury, and myocardial infarction. Many medications such as corticosteroids and amiodarone also can affect thyroid function measurement. There is no treatment for euthyroid 6 syndrome other than treating the underlying condition, which resolves the thyroid function test abnormalities.